right, so welcome back to healthcare processes and decision making. This is part four. So, in parts one through three, that's hard to say. In parts one through three, we explored the classic paradigm of patient clinician interaction, the types of information clinicians use, and the approaches systematic, pathophysiologic, heuristic, and mathematical that guide diagnostics thinking and decision making. In part four, we'll take the next step, looking at how information systems, clinical workflows, and decision support tools shape not just individual diagnosis, but the entire process of care delivery. We'll connect the human side of reasoning with the technological systems that clinicians depend on every day. This part is about seeing the bigger picture, how clinicians think, how data flows, and how the culture of healthcare brings people, processes, and technology together in the surface of safe, effective decision making. All right, so we're going to cover just a few of the objectives in this lesson since we described most of them in others. And some of these will be repeats, but from different perspectives. We'll describe techniques or approaches used by clinicians to reach a diagnosis. And again, why this matters to clinical engineers, is that clinical engineers don't make diagnosis, but that the technologies they design, maintain, and integrate feed directly into diagnostic reasoning. So, by understanding the techniques clinicians use, systematic approaches, pathophysiologic reasoning, heuristics, and mathematical models, engineers gain insight into what kind of information is most valuable, how quickly it must be delivered, and how it should be displayed. How we'll dive deeper? Well, we'll look at real world diagnostic frameworks and map them into the devices, monitors, and systems that support those steps. For example, how imaging systems support topographic reasoning, or how lab analyzers contribute to probabilistic models like Bayes' theorem. And this is going to help you see where technology strengthens or sometimes even undermines the diagnostic process. The other objective is to describe the role of EHRs and technology in the clinical decision making process and why this matters. Again, electronic health records or EHRs, decision support systems, and integrated data platforms are now the nervous system of the modern healthcare system. So, for clinical engineers, ensuring that devices communicate seamlessly with these systems and that data is reliable is central to patient safety. Poor integration or inaccurate data can distort clinical judgment as much as a broken device at the bedside. How we'll dive deeper in this lesson on this objective is that we'll unpack the specific ways that EHRs influence clinical workflows, how they store, organize, and present data, how decision support tools flag risk or suggest treatments, and how communication tools like apps and health information exchanges expand the reach of care. We'll link this back to the engineer's role, making sure that the technology behind these systems is safe, interoperable, and designed to fit into how clinicians actually think and work. So let's talk about the myth of choosing therapy. So, at first glance, the clinical process might seem straightforward. A patient presents with a problem, the clinician makes a diagnosis, the treatment is chosen, the problem is resolved. It sounds neat and linear, almost like following a flow chart. Clinicians may even use scientific evidence or guidelines to select the quote, right unquote therapy. Hopefully, I said that correctly. Quote unquote, right therapy. I think that's the way it's said. But again, here's the reality. This view is overly simplistic. In practice, choosing therapy involves uncertainty, competing priorities, and a constant balancing act. Patients often have multiple conditions at once, treatments may conflict with one another, and evidence doesn't always apply perfectly to the unique individual sitting in front of the clinician. For example, a therapy that works in a controlled study may be unsafe or impractical for a patient with other illnesses, or they may have limited resources, or maybe they have different goals of care. For clinical engineers, this perspective is essential. The devices and technologies we support are not used in isolation. They are part of a complex decision making system where trade offs matter. Our role is to ensure that the technology is reliable, safe, and adaptable so that when clinicians face these complexities, they can trust the tools that are in their hands. Well, let's talk about the reality of choosing therapy. So, last time we talked about the myth, the oversimplified idea that therapy is a straight line problem diagnosis, treatment, resolution. This might be the way some business management might see what's happening in the clinical world. The reality is far more complex. When clinicians choose therapy, they balance a web of influences around the central patient care problem. Scientific evidence matters, but it's only one piece of the puzzle. Patient preference guide the choices that they make, what the patient values, or what they can realistically accept. Coexisting conditions complicate the treatment. What helps one disease might actually worsen another. Economic constraints, right? The cost of drugs, devices, or access to services. All of this can limit the options. Organization imperatives and local practices influence what's available or allowed in a given hospital. Even social factors and personal experience weigh heavily in tailoring therapy to the individual. So, therapy is not chosen in isolation, it's a dynamic, multidimensional process where clinicians integrate evidence, context, and judgment. For clinical engineers, this reality underscores why technology must be flexible, accessible, and reliable. Devices, information systems, and support tools can't just deliver ideal data under perfect conditions. They must adapt to real world constraints and help clinicians navigate complexity. Move into individualizing management. So, when it comes to choosing a management plan, clinicians don't simply follow a single evidence based path. Instead, they must individualize care, tailoring decisions to the unique realities of each patient. Let's walk through some examples. So, let's talk about coexisting conditions. Imagine a patient with both hypertension and diabetes. The recommended first line therapy is an ACE inhibitor because this drug offers special kidney protective benefits for diabetic patients. Patient preferences, sometimes it's the patient's value that shapes the plan. For example, whether to order a prostate screening test, a PSA, that may depend entirely on the patient's personal preference. You have social and cultural factors. Consider a patient dying of lung cancer who is a Hmong immigrant, right? Contrary to assumptions of many U.S. hospice providers, this patient might prefer not to die at home, which must be respected in planning care. We can have economic limitations as well. Even the best plan may not be possible if the patient lacks financial resources. A new heart murmur in an uninsured patient may lead to a watchful waiting, right? Approach instead of something immediate. Right? Costly diagnostic testing would just have to be put to the side for that. Sorry, I'm just getting a little. When we deal with these kinds of issues, it affects everyone a bit emotionally. Okay. Let's talk about the scientific evidence now. Let's go to the other side of that, the logic instead of the emotional. So, for a patient with a peptic ulcer disease, guidelines say proton pump inhibitors, right? PPIs. That's more effective than H2 blocker. But because PPIs are more expensive, the cost may push the clinician and patient to consider the alternatives. But local practices might be something that influences the care as well. Referral patterns and availability of procedures, they vary by region and hospital. So what's possible in one setting may not be standard in another. Specialist availability and preferences. So different specialists may have different ways of approaching the same condition depending on their training and expertise. Then you have the clinician experience. A clinician is often safer and more effective using a familiar drug or procedure, even if another option is said to be better because familiarity reduces the risk of error. We also have organizational imperatives. Sometimes decisions are constrained by hospital formularies or insurance plans, which may limit drug options to a specific subset, regardless of clinician or patient preference. The takeaway is that individualizing management is complex. It's about weaving together clinical evidence, patient context, and real world limitations to arrive at the best possible plan for a given patient. So, for clinical engineers, this is just a reminder that technology isn't just about being the most advanced on paper. Devices and systems must be practical, affordable, and adaptable to these same complexities so that they truly support clinicians in tailoring care to each patient. Let's talk about decision analysis. When choices are complex and stakes are high, clinicians sometimes turn to a structured tool called decision analysis, and here's how it works. They list the options available. So, for example, recurrent angina after bypass surgery could be treated with medication, right? PTCA, angioplasty, or another bypass. You can list the possible outcomes of each option. Medication might lead to improvement, deterioration, or even death. PTCA could succeed, fail, or require another procedure, and each pathway has its own set of outcomes. They also assign probabilities. So, based on clinical evidence, clinicians estimate the likelihood of each outcome. Say a 60% chance of improvement, a 34% chance of deterioration, a 6% chance of death for medical therapy. So, we have to take all that into consideration. And then asking the patients for utility values. This step makes decision analysis unique. It incorporates the patient's perspective. For example, how much value does the patient place on short term improvement if it comes with long term risks? Tools like time trade off exercises help capture these preferences. Then you can calculate the expected utility. Multiply the probability of each outcome by its value, then sum them up, and this produces a numerical estimate of the overall quote unquote worth, hopefully I'm saying that correctly, of each option. Right? So compare options. In the example here, the PTCA has a higher expected utility, 0.62, then repeat bypass, 0.42, or medical therapy, 0.55. Account for heuristics and biases. Even with all the math, real world decisions can still be swayed by shortcuts, fears, or biases. Decision analysis helps counteract that by making the trade offs explicit. And for clinical engineers, decision analysis highlights why accurate and reliable data are so important. The probabilities that drive these calculations come from diagnostic tests, monitoring devices, and outcomes data. So technologies that engineers help ensure are safe, calibrated, and trustworthy. If the inputs are wrong, the entire analysis and the patient's future could be jeopardized. Okay, let's go ahead and talk about the SOAP process model. One of the most widely used structures in healthcare documentation and reasoning is the SOAP model, SOAP. It stands for subjective, objective, assessment, and plan. And the subjective is this. This is what the patient tells the clinician their symptoms, feelings, or perceptions. So, an example would be I feel short of breath when I walk upstairs. For clinical engineers, this reminds us that technology doesn't replace the patient's voice. Our devices must complement, not overshadow, what patients report. Now, the objective. These are measurable findings, the vital signs, lab results, imaging, and physical exam data. The example would be a pulse oximeter reading of 88% or an EKG tracing. Here, clinical engineering has its strongest tie. Engineers ensure that devices generating these objective measures are accurate, calibrated, reliable, because clinicians build critical decisions on them. And then the A is for assessment. This is where clinicians synthesize subjective and objective data, combining both into some working diagnosis or impression. An example would be shortness of breath plus low oxygen saturation may lead to suspected diagnosis of pneumonia. And clinical engineers, again, support this stage indirectly, ensuring that clinical information systems correctly display and integrate data from multiple devices so clinicians can make sense of it quickly. And then the last letter is P for plan. And the plan is the outline for treatment. What do you do next? From medications to procedures to follow ups. The example here would be starting antibiotics, ordering a chest x ray, or scheduling a follow up appointment. Again, for engineers, the plan may involve supporting the safe use of technologies included in that treatment. For example, infusion pumps, ventilators, diagnostic equipment. The SOAP model shows us that clinical reasoning is structured, layered, and dependent on reliable data. For clinical engineers, it's a reminder that every reading, every alarm, and every interface we support contributes to this process. If the technology fails, the whole chain from subjective reports to the plan of care can be compromised. So let's talk about medical records that guide and teach. In 1968, Dr. Lawrence Weed revolutionized the way that we think about medical records. He argued that records should do more than document what happened, they should guide care and teach clinicians in real time. Weed's model emphasized a structured plan with three key parts: diagnostic, therapeutic, and patient education. With diagnostic, that outlines what further information or tests are needed. With therapeutic, it's a detailing treatments or interventions to be pursued. And with patient education, it's ensuring patients understand their condition and plan of care. So this three-part plan served two powerful purposes. First, it reminded clinicians of uncertainty, that every plan is provisional and must adapt to new informational outcomes, new information when it emerges. Second, it highlighted the importance of patient inclusion, making sure patients are partners in their care. And another important feature is continuity over time. A well structured record doesn't just capture today's decisions, it provides a roadmap that helps future clinicians across visits and even across institutions. This helps understand the reasoning behind past choices. And for clinical engineers, Weed's insights connects directly to today's electronic health records and decision support systems. These systems must be designed not only to store data, but also to guide safe decisions and teach clinicians. So, for example, by flagging interactions, medication interactions, reminding providers of monitoring steps, or embedding patient education tools, engineers play a key role. I was going to say very key role, but a key role in ensuring that these systems are reliable, interoperable, and user friendly so the record truly becomes a partner in patient care. So let's look at the management plan in the SOAP format, right? The SOAP format being subjective, objective, assessment, and plan. It doesn't stop at diagnosis. It extends into management by clearly organizing next steps for each identified problem. And let's look at two examples. Problem number one, let's look at polydipsia and polyuria. So the diagnosis: order blood sugar, hemoglobin A1C, and urinalysis to confirm diabetes. Treatment: begin with lifestyle interventions such as diabetic diet and an exercise prescription. And the patient education: connect the patient with a diabetes educator and refer them to a local support group for long term success. The second problem: high blood pressure. Diagnosis: order the EKG, urinalysis, and serum electrolytes to evaluate complications and rule out secondary causes. The treatment: recommend a low salt diet, regular exercise, and if necessary, prescribe a diuretic. And patient education would be to provide a hypertension handout and direct the patient to trustworthy websites for continued learning. What's important here is that management is multifaceted. It combines diagnostic testing, treatment interventions, and education. And the SOAP structure ensures that each component is deliberate and documented. Nothing is left out. So, for clinical engineers, this highlights how technology supports every step. Diagnostics rely on accurate lab equipment, analyzers, and monitors. Treatment often involves devices such as blood pressure monitors, infusion pumps, and in this case, glucose monitors. And then patient education that can be enhanced by apps on your phone, portals to their health records, EHR link resources that engineers help maintain. In short, management planning isn't just about prescribing medications, it's about building a system of care where diagnostic tools, therapies, and educational resources all align. So let's talk about evolving management plans. Management in healthcare rarely stops after the first step. Instead, it evolves through layers: initial, secondary, and tertiary plans, as clinicians respond to how the patient's condition develops and to what the tests reveal. Let's look at a few examples from the GI and cardiac systems. So we see here on the slide, the first one is GERD, and the initial plan was trial of a medication. The secondary was a follow-up appointment for decisions, and the tertiary, if unresolved, proceed to the EGD, which is the esophag- esophageal-gastroduodenoscopy. I apologize for that. Um, and then the next one is the PUD, bleeding. So again, initial would have been looking at labs, secondary would have been another EGD, and tertiary would be to look at the H. pylori therapy, which can be costly. Excuse me. Gastritis, in this case, initially looking at lifestyle education, and then secondary, again, going to an EGD if symptoms persist. And then looking at the next one, the non-ulcer dyspepsia, right? Managed as a diagnosis of exclusion, secondary testing only if needed. Looking at the gallbladder and pancreas, jumping to tertiary imaging, which may include things like CT or ultrasound. And we talked about the zebras, right? The rare causes like cancer. If common causes are ruled out, then you can escalate it to performing an EGD or a CT. Now let's talk about cardiac. Um, Looking at CAD, for example, coronary artery disease. So initial therapy being something like lifestyle changes and education, secondary evolving to exercise, stress testing, and tertiary considering aspirin or other advanced interventions. The key here is that management is dynamic. It starts conservatively, escalates based on results, and always weighs risks, costs, and patient preferences. For clinical engineers, this layered process highlights how different technologies come into play at different stages. Initial stages may rely on simple lab analyzers or home monitoring devices. Secondary testing requires advanced imaging or stress testing equipment. Tertiary stages may use high-end diagnostic tools like CT, ultrasound, or interventional technologies. And engineers ensure that all these technologies are functional, integrated, and cost-effective, supporting clinicians as they move through each step of evolving management. And so I mentioned clinical engineering, clinical engineering, clinical engineering. But if you're a biomedical engineer and you work at a research lab or in academia and you're looking at designing a device, these are things that you should probably be looking at even before you. These are things that you should probably be considering as you design the device to make that integration into healthcare seamlessly. Seamless. Okay, so let's go ahead and summarize what we've covered so far. In this lecture, we examined how clinicians moved from diagnosis to therapy and management planning. We explored models clinicians use to choose therapy and how management plans aren't linear or simple. Instead, they require balancing evidence, context, and patient values. We discussed the process of individualizing patient management, tailoring treatment to coexisting conditions, patient preferences, economic realities, and organizational constraints. And finally, we looked at techniques that assist in creating a management plan. So, decision analysis, which provides a structured way to weigh risks, benefits, and probabilities. We talked about SOAP notes, which ensure care plans are documented clearly and consistently, connecting diagnosis, treatment, and patient education. And for clinical engineers, the takeaway is this: the reliability of every decision depends on the reliability of the data and technology behind it. Devices, information systems, and records must work seamlessly so that clinicians can focus on what matters most, making the best possible decisions for the patients. I want to thank you for your time, and I will see you on the next episode.